and there will be 15 minutes for questions. If there are any questions that occur to you during the presentation, then please put them in the chat session, and we will try to return to them after after the presentation's been done. If you could leave your cameras on, that would be great, because it's nice to see who's there, but remain on mute until the questions when you're speaking. And yeah, I think that's probably about it. So we can start with the presentation now. So it's a really great honor to be chairing this and introducing Professor Rachel Elliott from Manchester. The title will be the Medicine, Safety and Preventable Harm, a Health Economics Perspective. Rachel's a professor at Manchester, as I said. She's also the lead of the Manchester Centre for Health Economics. And she's also the economics lead for the Manchester NIHR Patient Safety and Research Collaboration. And she's previously been the director of the Manchester Clinical Trials Unit. Interesting to note that she is also a UK registered pharmacist, one of many pharmacists who's turned to the dark arts of health economics. It seems to be a particularly fruitful area to recruit from, but it's really interesting to see that she's a pharmacist, was the first full-time critical care pharmacist in the UK, and completed her journey to the dark side of health economics in 1996 with a PhD. She is a multi-million-pound research portfolio in applied health economics, which has influenced health policy and practice in the UK and internationally. She's also very impressively completed a Harkness Fellowship at the Harvard Medical School and has authored 2 books and over 150 research publications, of which a key theme has been the economic impact of medication error, with specific interest in understanding both the health and non-health outcomes associated with cross-therapeutic interventions. And that's what the presentation is going to be about today. I just note that the last publication on this, which I think was in 2021, already has over 200 citations. So it's already been very well read, I think, in the community. So without any further ado, or bumbling along from me, I shall hand over to Rachel to present her work today.
Thanks, Chris. I'm not sure I want to thank you for reading all that out. It's really nice to see so many people here today, and some familiar faces and faces I don't know. Am I right to share my screen? Yeah, okay. So I'm just going to reduce everybody to a thumbnail so I can see my whole slide. So I apologise if I can't see people's faces for the moment. I'm going to talk for 40 minutes, and if you've got any questions, please put them in the chat, and this will give us some time for questions. I've slightly changed the title, of course, because don't we always, but it's pretty much the same, medication safety and preventable harm, just a perspective from sort of health economics. And so I'm going to just talk a little bit just general about general sort of introduction to health economics and medication safety. And then I think one of the key things that I want to sort of look at today is ways in which we can estimate harm and costs from medication errors, because that's what we're interested in economics to an extent. And then I'm going to pull out these methods from 2 pieces of work that I've been involved with. One of them is a case study around looking at interoperability on patient safety, and the other one is around hazardous prescribing in primary care. So that's sort of what I'm going to try and cover today. So I think there are quite a lot of ways in which health economics can contribute to optimizing medicine safety. I'm not going to talk about all of them today. I think there are 2 sort of very policy relevant questions that we can ask and answer as health economists. So first of all, what's the impact of sort of suboptimal medication safety? So we know that medication errors can lead to harm, and that can lead to patient morbidity and mortality, and then that's burden for the healthcare service to manage those that morbidity, and also societal burden, costs incurred beyond healthcare, so social care, patients' own costs, loss of productivity, loss of people being able to do their sort of normal daily activities, whether they're paid or unpaid. And So these types of studies are useful up to a point, particularly for targeting policies and research and resources to areas with maybe the highest burdens. They help to highlight where the issues are worst or need more resources directing to them. And then most solutions to improve medicine's use, medicine safety, cost money. And so therefore, we're not just interested in whether they're effective, we're also interested in how much it's costing us. And so looking at it looking at these interventions, policies and systems from a health economics perspective, we can look at efficiency, which is a combination of or trade-offs between costs and benefits. So we're looking at the incremental or increasing cost of the new intervention and the extra benefit that it's giving. And then that enables policymakers and decision makers to target resources to sort of not just effective interventions, but to efficient interventions. So I just wanted to, before I move on, I'm going to focus on these two issues today, but actually, as a health economist, I'm also interested in the other impacts of a suboptimal safety beyond health, because obviously safety is more than just about health. And so if you have a medication error and it leads to harm, then obviously that's a health disbenefit, and there's costs associated with managing that harm. But there are also other non-health effects of errors, such as lack of trust in the health system, impact on the health service professional or social care person who's actually involved in that sort of situation. There could be litigation costs if the system is sued by the patient or patient's family. So there are sort of issues beyond health, which is another seminar. But today I'm going to focus on sort of health effects and the cost effects today. There's lots of studies out there that give big high-level figures around the impact of preventable harm in general. One of the leading causes of global disease burden. The disability adjusted life year burden from harm from healthcare in England is estimated to be around the same as that from multiple sclerosis and higher than cervical cancer. So I'm never quite sure how useful these numbers are, but it sort of tells you that this is a big issue. So there's some data here. So 15% of acute care costs are a result of adverse events. The cost of preventable harm in the UK, huge numbers of variation in these estimates depending on what methods are used and what data are included. So for example, if you include litigation costs, one estimate puts it at 3.8 billion. And often we're compared with other industries. Not always appropriately compared, I think, but we do apparently spend less on harm prevention than dealing with the consequences of harm. And there's a study from the US that suggested that managing VTEs cost a hospital 4 to 6% of their budget, but they actually only spent 0.13% on preventing them. So, which suggests that if they spent more on prevention, they spend less on treatment. Obviously, these interventions, as I mentioned before, are costly, and sometimes there are variable incentives for healthcare providers to invest in safety interventions. So they want to see what they're getting for their money. When we started working in sort of the economics of safety, a lot of the work was in secondary care, but actually most care actually takes place in primary care, and historically there's been less research here. And I think that a lot of the work that the PSLCs are doing is expanding that work in primary care. So I think that we are actually starting to see a lot more work being done in that forum. So let's just think about quantifying the impact of suboptimal medication safety before we move into sort of looking at some of the methods. So, obviously there are lots of questions that we might want to know the answers to. So how often does a hazardous medication event or an error occur? So some of the work that I do, we don't use the term error because sometimes these high risk prescribing events are not errors. People are actually, prescribers and patients are actually using medicines in a way that have a higher risk of a hazardous event occurring, but it's intentional because the benefits are deemed to outweigh the disbenefits. But for shorthand, I'm going to use the term error in this presentation, but that's just to say that it's not always an error. But I think for today, we're going to be looking at preventable harm, so we will use the term errors. So how common are errors? Where are they happening in terms of setting? Is it primary care, secondary care, nursing homes? What stage of the medicines process are they happening at? So is it when they're prescribed, or is it when the patients are having them administered, for example? And then do they matter? So do these errors actually make any difference? So do they cause harm? So if you measure errors, medication errors, whether it's prescribing error or an administration error, then you're just measuring a process indicator. You're not measuring harm. So how do you link the error to harm? And then how do you attach a cost to that harm? Because it's quite difficult to do that. If you do a study, and I know I've seen Bryony's on the call here, she's done lots and lots of studies in medication error. Once you've identified an error, you can't just leave the patient to go on and have the harm, because as a researcher, you're interested in what's going to happen to that patient. It would be sort of pretty unethical. And so therefore linking errors to harm can be a little bit complicated, and I think that's one of the things that's one of the first part of this presentation I'm going to talk about, the two different ways in which we've attempted to do that, to link errors to harm, because that's the key bit where you can then look at the actual impact of the error, so in terms of on the patient, in terms of morbidity and mortality, and in terms of cost to the NHS and more widely. So two methods I'm going to talk about. This is a photo of Manchester in the sunshine. So this is quite a rare event as well. It's not a never event, but it's quite a rare event. So this is the first way that we did it. So we did some work. I think this might be the paper that Chris was kindly referring to. We did some work for Department of Health and Social Care when Jeremy Hunt was the health minister, where we were asked to with York, we were asked to estimate the prevalence and clinical and economic burden of medication error in England. So this paper came out in B&J Quality and Safety, and we made we did a sort of a modelling exercise where we estimated that 237 million errors are made in England per year, and that about a quarter of these can cause moderate to severe harm, with around 700 deaths. And this sort of went a bit viral, to be honest, which wasn't very relaxing for me as an academic, so I quite like to keep my head under the radar. And it showed that about 38% of errors were in primary care, 42% were in care homes, and 20% were in secondary care. So how did we do that? Okay, so I'll just talk you through how we did this. So first of all, we knew that there were about 1 billion items prescribed in primary care per year in England. This is publicly available data. We had a study from Tony Avery, who most of you will know is NHS prescribing, clinical director of prescribing for NHS England. Has done a lot of work in probably one of the leading researchers in the world in medication safety. So we know that primary care prescribing error prevalence is about 4%, and there was an assessment done of these errors. Obviously, as I said before, you can't just leave the errors to manifest into harm. So when you have a set of errors as a researcher in front of you, obviously you then stop the error from propagating. But then how do you know whether it's a minor, a moderate, or a severe error? Well, you sit down with a group of experts, sort of pharmacists and GPs and other prescribers, nurses, etc., and you say, right, okay, if this error hit the patient, would it cause harm? And so it's a sort of a judgment call. And so the work that Avery's team did suggested that they looked at these errors, it's 4.2% of errors, and suggested that about half were mild, half had the propensity to have mild harm or nothing really, and then about half could have caused moderate harm, and then 0.8% could cause severe harm. So we used those data, and other studies have done something similar to this as well. We then assumed that if somebody had a severe error, so that 0.8% of the 4.2% of the 1.1 billion, if they had a severe error, then we assumed that they ended up with a hospitalization, because they would have an adverse drug event. And we know that. And so per Mohammed's study, again, from Liverpool, hugely well-known researcher in this area. This is quite an old study, but it's actually been used a lot. And there is now, since we published this work, there is a more up-to-date piece of work now. But he and his team basically were able to follow up patients who were admitted to hospital with avoidable, with adverse drug events, that they made an assumption, or they judged that they were avoidable, and they measured the length of stay for these patients. The median was about 8 days, and they also measured the mortality of these patients, and about 2.3% of these patients died. So therefore, we were able, using these data, to do some fairly basic algebra to calculate there are about 21 million mild errors in England, 21 million moderately severe errors, and 0.7 million severe primary care prescribing errors, leading to a cost, leading to about 136,000 bed days, which cost 83.6 million, and around 627 deaths. So we did that. We did that across, this is just prescribing in primary care, but we also did it for administration and monitoring, etc. And we also did it for nursing homes and hospitals and transitions to give that overall estimate. So this is one way of doing this, and you can see that obviously that it's based on individual studies, it's based on some real prescribing data, but other than that, a lot of this is sort of making lots of assumptions to reach the end of these, to get these estimates at the end. So the other way to identify harm from an error we've done, and I'm just going to talk through one study, but there's actually two studies that we've been involved in. This one here is was done by Leonie Penner, who had a PSRC Manchester Centre of Health Economics joint funded PhD, and she looked at identifying the risk of serious harm associated with where you have a patient in front of you who's either on a warfarin or another oral anticoagulant and is then given a non-steroidal. And she looked at how we estimate the harm from that. And the way that we did it then was slightly differently from this other study, was we said, right, well, this is a specific error. So again, this is different from the other study because the other study is just looking at all errors. So it's just assuming some sort of similar level of harm across all errors across different diseases and different drugs. This is a different question. This is one very specific question. And in this situation, we've got the ability to go into this large data sets which link primary and secondary care data for individual patients in England. And we're able to say, right, well, if we find out, if we identify, we interrogate this database and we extract all the people that have had, who are on warfarin or another oral anticoagulant, and then we see if they've had a non-steroidal, then what we do is we go forward in the data set and we see whether they've had any of the serious outcomes that we think are or know are associated with using this combination of medication. And in this situation, we were hypothesizing increased risk of GI bleeds, stroke and major bleeds, and also systemic embolism. And then what you do is you basically take another population within the same cohort who haven't had that error, and then you look at their risk of these outcomes as well. And then we carried out, and this is done using a propensity score match population. So this study enabled us to identify the increased risk of these serious harm outcomes for this particular error using sort of, real prescribing and patient outcome data. So this was published in 2022. And what we found was that compared with patients who weren't on an oral anticoagulant, if you added in a non-steroidal, your risk of GI bleed increased by a factor of 3, increased risk of stroke, increased risk of major bleeding, but actually risk of systemic embolism didn't increase. So this is a different way of finding out, of linking the error to harm using a large routine data set. And this gives you the answer to a very specific question. So how did we use these data? So as part of a large program grant, Protect, we have built these models across 5 patient groups who are on non-steroid, who've been maybe prescribed non-steroidal inflammatory drugs in a high-risk situation. So people in older adults, people who've had an ulcer in the past, this one that I've just talked you through, sort of taking oral anticoagulants, people with heart failure and people with chronic kidney disease. And what we did was we took took data that linked the error to harm in the same way that Leonie Penner's paper generated those data to look at the risk of these outcomes. And then what we did was we built a model which allowed us to quantify the costs and the serious harm outcomes and quality adjusted life years for each of these 5 situations. So this work is still ongoing at the moment. It's under review at the BMJ. But this is just, this is the model that relates to Leonie Penner's paper that I just talked you through with the oral anticoagulant in combination. You can see on the left-hand side, you start with no adverse events. So it's the patient is just in a state where they have no adverse event. And then there's a probability for somebody who's on warfarin, for example, that they might have GI discomfort, they might have a stroke, they might have a serious GI event, they might have a symptomatic ulcer. And if you add in the non-steroidal on top of that, you increase the risk of those events. So what we were able to do was to build this model and populate the probabilities from that study that Leonie had done. And then we took other data to tell us how much it cost to be in each state. And then we also took other data to tell us what your health status was in that health state. And that will allow us to generate overall costs and overall QALYs. So I'm not going to go into the results in great detail, but one of the things that we did do was we also represented the outcomes or the harm in a simpler way, because you can see here from this model that we can generate how many ulcers and stroke, for example, and GI bleeds are likely to happen because they're in this model. So what we did was, one of the ways that we presented the results in a simple way is that this graph shows for these 5 errors, so these 5 times where you're giving non-steroidals in a risky situation, these are the sort of excess events or the sort of preventable events that can occur if you're using these non-steroidals in these groups in England. So this suggests that over 10 years in an English population, there are going to be 778 deaths, about 1,400 ulcers, about 1,900 bleeds, about 1,700 strokes, about 6,700 acute exacerbations of heart failure, and about 3,200 acute kidney injuries. So this is these are estimates of sort of serious harm outcomes, and then we can attach costs to that as well. So this is using methods that are very similar to the Penner study that I've just shown you. So you can see that this is a different way of estimating harm from errors. The difference between the 2 methods is that the estimation that we did where we calculated the 237 million errors, that's a lot quicker and cheaper than this. This is more complex to do, and also it's more granular because the way that we do it at the moment is that we have to do it separately for each specific error. So but with this, obviously, you get information that's probably more specific and potentially more accurate to the specific error. So what I'm going to do now is just talk through the 2 case studies of interventions that are intended to improve medication safety. And the first intervention is where we've used the method that's similar to the 237 million errors method, where we've extrapolated just errors and then estimated mild, moderate, severe errors and then estimated bed days. So that's what we've done with this medicines information operability intervention. And then I'm going to move on to the Pincer intervention, where we've used this more sort of more error-specific modelling approach to estimate harm and cost. So back in sort of the probably 6 or 7 years ago, the NHS NHS England decided that to introduce some information standards. And this was to enable systems to transfer medication and allergy information digitally between, say, primary care and secondary care, so that it wouldn't have to be manually transcribed anymore. And locally, lots of hospitals and GPs are able to do that already, but nationally there was no system. And a lot of hospitals didn't have fully electronic prescribing, which meant it was difficult for them to transfer to give information to primary care, for example. And so this new system was very disruptive sort of technology to do this across the NHS. And we were tasked with looking at the impact on patient safety. So there's a lot of work being done around this. And so we were given we were asked to do a particular piece of work where we were asked to estimate the impact on medication safety. And as we had to do this fairly quickly, for us as academics, it felt quick anyway, probably for NHS England, it felt interminably slow. We used a similar estimation method to the method I talked about with the DHSC work that we did with York. So what we did was we looked at people who were at risk of experiencing what is called a transition medication error. So this is an unintentional error when somebody transitions from primary care to secondary care, or secondary care to primary care, within wards where you might have differences in electronic systems. So you go from the emergency department to the ward and it's a different system. So your medicines information has to be transcribed. And then if you transfer between hospitals, those were the 4 transitions that we looked at. And our intervention was this digitally enabled interoperable medicines information transfer, compared with the standard of care, which is sort of manual medicines information transfer. And the outcomes that we focused on were the error rates, hospitalizations, adverse drug events, length of hospital stay, readmissions, and deaths. And so we tried to answer these 3 questions. So what's the incidence of medication errors at key transitions? What's the harm and cost of those errors? And if we have improved information transfer on medication errors, so how will improved medication information transfer hopefully reduce medication errors? And then what impact does that have on associated patient harm and NHS cost? And obviously this was a desk exercise, and we were using available evidence and working very closely with a range of stakeholders, local and national stakeholders, that made this piece of work possible. So this just shows that it was basically, we did one literature review to look at transition error incidence, another literature review to look at transition error harm and costs, and then another literature review to look at the effect of interoperability solutions. So how much do they reduce errors? And then this allowed us to estimate the effect of these solutions on errors, harm and cost for England. So this gives a summary of the results that we found. So similarly to the work that we did for DHSC, we've reported sort of numbers of transition errors, number of patients with harm, excess bed days, and then we've calculated the cost of excess bed days, and then we've got the deaths from harm. So if you look at the right-hand column, it shows us about 1.8 million errors at those 4 transitions over a year, with about covering about 378,000 patient episodes, and of those about 31,000 causing harm, with some excess bed days, leading to about just under £80 million worth of costs, and potentially 45 deaths. And this was assumed to be in the presence of standard medicines reconciliation, because you can't carry out these interoperable solutions without there already being some form of manual reconciliation in place. So then we looked at how are these baseline estimates of errors and harm and costs affected by the use of interoperable solutions. Now, we don't have any estimates of how effective the interoperability standards are. So we had to go to the literature and see what was out there. And there were no specifically relevant UK studies, but we did find some studies from other countries. So what we actually did in the paper that was published was we looked at a range of effectivenesses of reduction of errors. And so this one here, this estimate here is if you reduce the errors by 50% by having these digital interoperability solutions, then you're looking at, halving your number of errors and reducing the numbers of people with errors, reducing the harm and reducing the deaths. So I think this might be 60% actually, or 56%, 56% reduction. So this was a way of showing that if you use these interventions, if you introduce these interoperability standards into your trust, and this disruptive technology is managed, that you actually now you are going to have an impact on costs, and you are going to reduce patient harm. So that just come out this year actually in BMJ Quality and Safety. So that's using the first method to try and estimate harm and costs from errors. And then this intervention, Pincer intervention, which some of you will be familiar with, uses the sort of the modelling approach that I've also outlined. So for those of you that don't know, Pincer is a pharmacist-led IT-based intervention where you go into the GP clinical system to interrogate the system to identify patients at risk from a set of 11 prescribing errors. And then the pharmacist works with the general practice to develop an action plan to correct the errors in the patients that have identified, but also to come up with plans to prevent these errors from occurring for future patients. So this is sort of a complex intervention of sort of IT and sort of human sort of academic detailing. And this is shown to be effective as an intervention in both a trial and in a regional rollout, and a national rollout is also the data are being analysed, but it's showing to be an effective reduction in errors. So at 6 months and at 12 months, you're seeing a reduction in prescribing errors. This is compared with the control group. So this is a bit of a busy slide. You don't need to worry about this too much, but just show that these are the 11 prescribing safety indicators, and you can see that 6 of them are around reducing GI bleeds, and then we've got 2 around reducing asthma exacerbation as a serious harm outcome. Non-steroidals feature regularly, so prescribing non-steroidals in heart failure is linked to the heart failure outcome. So we've just published a paper in BMJ led by Pearl Mock and Darren Ashcroft, which looks at the harm associated with using antipsychotics in people over 65 with dementia who don't have a diagnosis of psychosis. That's actually, again, that's had a lot of press interest. So that's a really important paper. I haven't gone through that paper today, but it does a similar thing to what Leonie Penner's paper did with the oral anticoagulants and non-steroidals. So hopefully that will have some impact. And then kidney injury is the other outcome. So these are the indicators that were covered by Pincer. So the way in which we think about this as health economists is we think about our patient population being at risk of an error, and then we either use Pincer or we don't. And then using Pincer should reduce the probability of an error. And so the trial and the rollout measure those error differences. And what we wanted to do was to actually say, well, okay, we've got these errors that we've identified, and Pincer has reduced the incidence of those errors, both in the trial situation and in the regional rollout situation. What we want to do as health economists is go from those errors to estimating overall patient harm and costs. And that's where we had to build 11 models to equate to each of those 11 prescribing safety indicators that I've just shown you on the previous slide, so that we could estimate the harm and the costs associated with those errors. So the slide that I showed you earlier that showed the harm associated with non-steroidals, so things like how many more strokes, how many more GI bleeds, how many more deaths are we going to get from prescribing these medicines in these high-risk groups. So we built the 11 models, and that enabled us to generate the cost of harm and the quality decrement, or the reduction in quality of life and quantity of life caused by these errors. And then we also know which of so these are the 11 indicators, and then these numbers tell you sort of how the prevalence of these errors. So you can see that, for example, if you look at G, the use of a non-selective beta blocker in asthma, that's quite a high prevalence of that particular prescribing indicator. You know, there's about 1.2% prevalence or patients at risk, for example, of patients with chronic kidney disease being prescribed a non-steroidal. So we knew which of the errors would likely to contribute the most in terms of harm, just through how commonly they sort of occurred. And then we knew the effectiveness from the trial and from the rollout data. We also did a fairly complex costing exercise around how much it costs to use Pincer, and that allowed us to build a composite economic evaluation. And so this is a bit of a bus timetable, but what this shows you for each of the indicators, if you look at the top row, you've got indicator A, which is giving somebody over 65 a non-steroidal, but no gastroprotective agent. That in one practice, this is a practice level intervention. In one practice, you have 69 people at risk, and if you don't have Pincer present, then you will likely have 24 errors. With Pincer, you get 18 errors, so you reduce the number of errors per practice over 6 months by 5. And then when you take that error difference of 5 fewer errors and convert that into harm in terms of bleeds and deaths and the costs associated with that, you see a net improvement in quality adjusted life years and a net reduction in cost. So we've done that for each of those prescribing safety indicators, which showed us that the total cost saving in a practice, if you reduce the errors, was about just over £500, and that you would gain 0.14 of QALY, and then the intervention itself was about just over £1,000 per practice, and then so therefore the overall net cost or increase in cost overall, once you took into account reduction in costs from harm, was at just over £800. So you have a cost per QALY of £5,500. So presenting this on a cost effectiveness plane, which is what health economists like to do, whether non-health economists understand it or not, but we always like to do this. You can see that this is the incremental cost on the y-axis and the incremental QALY on the x-axis, and you can see that there's an increase in QALYs from Pincer over standard care or current practice, and there's an increase in cost per practice if you use Pincer over standard care. So the incremental cost effectiveness ratio is in the northeast quadrant. So it's more expensive and more effective and more expensive, which means that you get more benefit, but you've got to bring money from somewhere else to pay for it. So you've got to make a decision about whether you think that extra benefit is worth that extra cost. And by translating the outcomes into QALYs, we're able to move into the world of NICE, where if a cost per an extra QALY is under £20,000, then we will consider that the intervention is cost effective and therefore good use of resources. So the green line is a cost per QALY of £20,000, and the red line is a cost per QALY of under £20,000. And so therefore you can see this intervention is cost effective. So for most people at NICE, and I was on a NICE approach committee for 17 years, this is really sort of speaking my language, and I understand that. But for a lot of people, they don't necessarily find this particularly useful. They may not understand it, they may not trust it, and also it's not the parameter by which they make their decisions about resource allocation locally. So we know from work we've done, and I see Lee Charles in the audience, and when she did her PhD a long time ago, one of the papers she published was around how local decision makers use economic evaluation, and basically the answer was they don't. They just want to reduce costs, and so therefore this type of evidence is useful in some contexts but not in others. So we are actually applying for funding through a programme development grant at the moment to be able to take these models that we've developed and turn them into a dashboard that allows local decision makers at ICB or sub-ICB level to be able to generate information around, if I reduce my number of these prescribing indicators, how many bleeds will I avoid, how, you know, that sort of thing. So it's similar in the way to that I presented for the non-steroidals BMJ work that we're doing. So I've talked through these things quite quickly, I think, but I'm hoping we'll have time for questions. I just wanted to say that as part of the PSRC, we've now developed an economics of safety network. And this is a collaboration to build a platform for researchers, providers, policymakers, and PPI participants, so that we can sort of use economics more effectively. Obviously, there are quite a lot of methodological considerations around the economics of safety, but also what we want to do is to optimize collaboration between people who are economists in safety and people in safety research who want to use economics but aren't quite sure how to do it, and so that those groups of people can engage, and also to build a sustainable network for people working in this area. There we are. There's a lovely photo. We had our hybrid launch event earlier this year. We've already had one seminar. We've got another one coming. I've inculcated my way into your Safety Net seminar series today. We've got an international seminar at the end of June. We've got blogs and articles in the newsletter. We've got a health economics placement potentially coming to MCHE from one of the PSRCs, and you know, the world is our oyster. So I'm going to stop now and pass it over to the audience to ask questions or comments. And stop share.
Thank you, Rachel. That was also beautifully kind as well as massively informative. So thank you for that. Okay, so do we have any questions? I didn't see any pop up in the chat. If you could raise your hand, then I can hopefully see if anybody's asking any.
Chris, I think there is actually a new question in the chat
sorry,
from
William. Okay, so William, do you want to step in and ask your question in person then?
Yes, thanks a lot. It was a really fascinating talk, actually. Apologies if this isn't quite directly on topic, but I'm a doctor. I work in secondary care and in a hospital that introduced electronic prescribing over the last few years. And I guess I was quite excited about the potential for electronic prescribing. You know, it could integrate and draw on safety science and things to improve medication safety. I think I've probably been a bit disappointed, to be honest. And I was just wondering if you knew how guided by safety science electronic prescribing systems are nationally, and how much they're drawing on that evidence base.
It's not off topic, actually. It's actually quite close to what we're working on at the moment. So alongside Pincer in the ProTech programme grant, we evaluated a clinical decision support system in primary care. So I think I don't want to speak for the whole of the NHS hospital electronic prescribing systems, but I will say from my experience, so please don't shoot me, don't shoot the messenger, is that I think that primary care is probably a little bit ahead of some secondary care on this. So for example, the systems that we've been working with, so OptimizeRx. Obviously, OptimizeRx has a lot of jobs that it does as a clinical decision support system. What it does is obviously it's interested in saving money, so stopping prescribing of unnecessarily expensive products, and the second thing is to enhance quality, so making sure that prescribers prescribing and monitoring is meeting quality standards. And then the third sort of job that these systems do is to use safety, is to have safety indicators in there. So for example, Pincer being integrated into, and not just Pincer indicators, but I know that OptimizeRx has got over 100 safety indicators in there. So that it's part of the day-to-day job of the system, that if a prescriber goes to prescribe something that would be considered a hazardous prescribing event, that it will flag up. So that's pretty much a standard part of primary care prescribing. I think that I don't know that it's a standard part of all electronic prescribing in hospitals, because I think to an extent electronic prescribing in hospitals is very heterogeneous in terms of how the systems are built. I think probably some are better than others. I know Bryony's on the call. I'm not going to ask Bryony to answer this question because it would be mean, but I do think that that there are moves to incorporate that into prescribing systems in hospitals. I don't know if that answers your question, but I know that in primary care that there's a lot of work being done on that already, but it's just as well whether people actually take any notice of all of these alerts, a lot of alerts.
Okay, thank you both. So Calandra in the chat has asked how she can join the Economics of Safety Network, so we can answer that one offline, I think. Bryony's made a point about the input from safety science rather than a question. Do you want to elaborate on that, Bryony, or is that?
I was just responding to William's question, but perhaps happy to discuss offline, as it is perhaps a slightly tangential discussion that we could probably fill a whole hour with in of itself.
A future seminar, I think, Bryony.
Maybe. I think that would be really interesting, actually.
Okay. Another question's popped up from Brooke, so I'll invite her to elaborate on that one.
Thank you. It's quite a broad question about health economics from the perspective of, well, whether how much is understood, how much is studied from the perspective of the impact on staff. If a member of staff's involved in an error, they might need to take time off, or even worse, leave the profession because of their feelings of responsibility. Is that something that you look at from a health economics perspective?
So I think this is one of the things I was mentioning at the beginning, because obviously, you know, safety interventions and the impact of safety is different from a normal intervention, because there's this notion of preventability. And so, you know, so we are very interested in the non-health outcomes of it, generally, sort of from a theoretical and sort of, you know, moral, ethical perspective. So for example, a really simple example is if somebody is prescribed somebody goes into A&E with a chest infection, and they're given a penicillin, and they have an anaphylactic reaction and they die, then, and they'll say, so they were 36 years old. Obviously, that's a death, which is unfortunate, and they might have lived till they were 72. So you lose 36 years of life. Okay, so that's the health loss. Okay, if that person goes into A&E and is given that penicillin and dies, then it turns out that it was in their notes that they were allergic to penicillin, then you now have a preventable death. But the health loss is still the same, okay, because you are still losing 36 years of life. But everybody on this call knows that that death that was preventable feels worse than the other one. The other one is unfortunate and tragic, but this one feels devastating, okay? So if you only look at the health impacts of safety interventions, you underestimate the impact of those interventions. Okay, so you underestimate the impact on, so obviously there's the health, right? So we've talked about that today a lot, you know, we can park that. But the non-health effects of this are under-researched. And we've actually tried to get funding from the NIHR for this in the past, and they've sort of, this program grant that we've just done, we had a stream on looking at non-health effects, which would have included the questions that you're talking about, and they sort of told us off for being too academic, and that they were just interested in health and costs and implementation. But I think that what's actually happening now is that views are changing, and that they're realizing that this is actually really important, because this is the key issue around safety. You know, is not just about the harm. It's about it's in terms of health, it's about all the other effects, you know. So we know there's research around the world that shows that if you know that a system is unsafe, you're less likely to use it, so you don't trust it. So people don't go and use that system until they're sicker. So therefore, so we call these, so they're called silent members, because they wait until this, you know, they won't go, they've got a little bit of chest pain, they'll wait till having a massive heart attack, and then you've got a much more complex health effect to cope with. In terms of the impact on healthcare professionals, I mean, I'm working in mental health, and doing economic evaluations around interventions that improve mental health of healthcare workers is to an extent is is interesting for health economics when we're looking at it within the paradigm of what's the impact on the NHS costs, because it's slightly outside that paradigm. So, you know, as a health economist, I'm really interested in exactly the question that you just asked, in terms of whether the NHS will, to what extent we'll get funding to do research on that, I don't know, but it's something that is actually really important. I don't think I've really answered your question, but yeah, you've basically come straight into an issue that's really important to me and to a lot of other people working in the economics of safety, and we could do a whole seminar on the other effects, you know.
Sorry, could I just jump in there? So I think you did answer the question, but I just want to add my little bit as well. I think it's a very important question you asked, Brooke. Really, really important. I think what we've seen today is Rachel implement into safety the standard health economic approach, which was supposed to be sufficiently generic to be applied to kind of any resource use. So theoretically, there's nothing stopping it from just being transplanted as Rachel's done. But I think there are nuances about safety, which Rachel discussed there, which are very different to its application in other areas. And this is why we feel it's very important that the non-health economists engage, because what you have to do is you have to tell us what the important factors are, what the drivers of benefits are, what the drivers of costs are. And it's in our job to try and incorporate them in the economic model. So I think this type of questioning is really important, super important at this stage, because it does feel that we are a little bit at ground zero for this sort of thing. I mean, Rachel's been working in it a few more years than I have. Has made amazing progress, I think, and really sort of set the landscape out nicely. But it's exactly those sorts of questions that we need to kind of make it useful, I think, in patient safety. So thank you for that. Okay, Rebecca's got a question there, a very specific one.
Yeah, sorry, Rachel. I was just really interested in your slide where you went through all of the impacts for the different types of drugs in different scenarios. And I noticed that one of the largest groups of patients were those on the non-selective beta blocker for asthma, and that Pincer didn't work for that, or there was no difference for that group of patients. And I just wondered if perhaps this wasn't you that explored it, but if you know why that was the case.
Oh, don't even get me started on beta blockers and modelling the impact on asthma attacks. I mean, I've just spent the last 15 years saying, can we just take it out as an error? Can we just take it out? Especially now that we know that beta blockers can actually help people with COPD. You know, just anyway. So basically, that indicator has changed from just beta blockers to non-selective beta blockers. And actually, what we've got are 3 models within that. One's the glaucoma non-selectives. The second one is the use of propranolol for anxiety, and the third one is the use of non-selective beta blockers in in cardiac conditions. So we actually had 3 submodels for that. So basically, if you look at that, there's a theoretical effect of beta blockers on increasing asthma attacks, okay? And a lot of when you go back to the original papers, a lot of them from the 50s and 60s when it was normal to use propranolol, you know, so some of the basic data is really out of date. But also, if you give what happens is, in reality, is if you give somebody a beta blocker, and they're at risk of an asthma attack, you can see an impact at the beginning of treatment. But if they don't have an asthma attack or an exacerbation of asthma within about, you know, I don't know, a week, 2 weeks, 3 weeks of starting the beta blocker, they're probably fine. So that's why, you know, the GPs aren't going to take them off them, because they've been on them for 3 years and they're fine now. You know, so I think that's why it doesn't work, because it's one of these theoretical, you know, beta blockers block the beta receptors in the trachea, so therefore blah blah blah. But actually, it's so much more complicated in reality. So it's still in the CSM, you know, so, you know, it has to be in there because it's one of these where it has to be in there. But actually, when you look at the actual evidence now, it just isn't supported. And I must say, one of the most soul-destroying aspects of my work on Protect is having to build models for beta blockers and the effects on asthma exacerbations, because the evidence isn't there to support it. And we've actually got models now where we have this transient effect in our models, where we have the initial impact and then we've got no effect later on. So,
thank you so much.
And I think if we incorporated the effect on COPD, you'd actually find that reducing beta blocker use in these patients might cause harm.
Thanks, Rachel. Thank you for that. And thanks for the talk. I thought you were going to say something entirely different, actually, because in a similar study that Robbie Foy has run, he found that where you identified large groups of patients that GPs might have to look at, the impact was less significant because they just didn't have the time or scope to look at that very large group of patients, but they were much more effective at looking at smaller groups of patients. So I thought you were going to say something like that in response, but that was really interesting to hear, and I've obviously opened a can of worms there.
Don't get me started.
Okay. Sorry, I see
John's got his hand up.
Yes, I was going to say John's got his hand up. I don't know how long it's been up there, but John, please.
Thanks. It's not been up too long. It's just going back to, I think it was Brooke's point really about staff and the impact on them, and it's not an economics point, but when I chaired an ethics committee, my ethics committee were very, very touchy and sensitive about questions that researchers might ask that might lead professional staff to expose themselves and to own up to doing things wrong. And they were very, very conscious that actually people were doing their best in busy environments to do a good job, and they didn't want to kind of make people feel in research that they were being criticised for doing things wrong. So the point I'm making, I suppose, is it's quite hard to do the kind of research that enables us to understand what these effects are. And it obviously needs to be handled in a sensitive way, but obviously there have been initiatives, haven't there, that have made it easier to report error. And usually we think that higher reporting error rates are a good thing, not a bad thing, because we think there is more error than people are actually owning up to. So there is something also in the system where we need to have this culture of openness and not the traditional culture, you know, especially maybe in nursing, of blame, like, and if you make 2 errors, you're not going to have a job any longer, and that kind of thing. So I just wanted to make those broader points as well. Really.
Yeah, I agree.
Okay, thanks. Well, that seems to be absolutely perfect timing because our hour is almost up, and all the questions seem to have been exhausted. Well, that we're allowing. Oh, one new message there. Just more thanks for the presentation. That's great. So we need to get back to Calandra to let her know how to join the.
So I think Ali is a research fellow working in health economist working at MCHE, Manchester Centre of Health Economics, and he's coordinating the economics of safety network. And if you just email him, he's put his email address in the chat. And what I'll do, if I do this again, I'll put his email on the slides, and then he can add you to our economics of safety network. Yeah, and obviously anybody is welcome to come. We're still sort of forming, so we're still thinking about what we need to do as well. So it's so there are some seminars, there are some talking heads, but also we want to talk about some of the issues that we've covered today actually.
Brilliant. Okay, well, it's just time to close the session today. Just to thank everybody for joining. Some really interesting questions, and of course a special thanks to Rachel for presenting our work today. Expertly done. Thank you very much.